Hello guys, today let me introduce Stephen Osborne, who is teacher in PDTR, and he will show us what is the difference between classical manual therapy approach and PDTR approach in treating functional issues.
So I've got Jack here, he's an associate of ours in the clinic, and he's been complaining of some neck issues for a little while. Jack, tell me what's been going on.
Yeah, so I've been experiencing quite a lot of discomfort around this right side, where it's causing me a bit of tension, headaches all around this right side. I've had it for quite some time. I've described it as just really stiff, tight, dull pain. Tends to be worse in the mornings, and yeah, it doesn't seem to get any better.
So from a traditional physical therapy standpoint, first things you'd want to be asking the patient is, are you getting any pins and needles, any numbness, any altered sensation down into the arm? Okay. Are you getting any migraines, any auras, any flashing lights, any floaters, anything like this?
Nothing like that.
Nothing like that. Okay. Have you not noticed any loss of strength down into the arm, loss of strength in movement into the hand, anything like that? Nothing like that. Okay, fine. Do you recall when you did this?
Nothing specifically. It's been ongoing for years and years, so I can't quite say when.
Okay, can you tell me when it gets worse? Does it get worse at times of stress or after activity, or does it get worse when you're playing sports?
It tends to be worse after I've had a stressful week, or actually when I've exercised my shoulders and neck.
Okay, so what we want to do then is go ahead and examine him. And so the first thing we want to do is sit up for me, and I'm going to get you to drop the head down, chin down to your chest. And so normally we expect to see the chin is flat to the sternum, and he's a little bit off that. We want to bring the chin all the way to the ceiling. He's actually not too bad. Generally like to see the occiput almost parallel with the floor, so he's a little bit off that, but it's not too bad. Look into the midline and get you to rotate around this way for me as far as you can. This way he's quite restricted to maybe 50, 60 degrees. To the left for me. That way is a little better, but still not perfect. Okay, now lateral bending, bring the ear to the shoulder. Okay, that's pretty restricted. And go the other way forward. That's perhaps a little bit better. So we can definitely see that there's some changes in range of motion. Does any of that trigger any pins and needles, any numbness down into the arm? Nothing like that. Okay, so now what we want to do is we want to have a little feel into the facet joints, coming down into the neck and then down into the upper thorax. So I'm going to drop the head down, and if we get you to rotate around here, so if I get you to face that way, I don't know if we can see. So what we want to do is we want to have a little feel into the articular pillars, which is just about there. We want to drop the head down, and we want to rotate. And I'm going to just let me know if anything is painful for you. So I can feel that. Is that sore for you in there?
Yeah.
Right there?
Yeah.
All right, going to come a little bit further down. And so what I'm feeling is there's general tightness. So the general tightness, but also he's saying it's painful. And so the painful is the inflammation, things like prostaglandins and histamine and cytokine, which is actually neurochemical signaling to say that actually there's still an inflammatory problem. Okay, I'm going to drop the head down. I'm going to come around on this side. How's this side into here? Is that painful as well, or not so bad?
Not as bad.
Not as bad. So much worse on the right-hand side, on the left-hand side. And so the fact that he's still painful on the right side suggests to me that he's got an ongoing irritation problem, because it's simply not plausible that Jack has injured himself a couple of years ago and he's still waiting to heal. Generally speaking, healing, it's called intention healing in biology. We heal as well as we're going to heal within perhaps a couple of months. If Jack is still complaining of pain as I'm assessing and palpating him, it's simply an indication that there's constant irritation and inflammation. So we want to view this problem not as a catastrophic injury that he's still waiting to recover from. It's more that he has an acute flare-up of a chronic problem. And so now what I want to do is get him lying down on his back. And so we want to assess that again, pressing into the articular pillars, and we can definitely see that there's some restriction into this area here. Okay, if we have a feel into the muscles, muscles don't feel too bad, a little bit more high tone perhaps on the right-hand side. If I press into the facet joints coming down, again, some restriction to the facet joints in the thoracic spine. Other than that, there doesn't really feel to me to be a smoking gun. So the diagnosis for this gentleman here would be that he has some facet joint irritation. The facets don't appear to re-trigger any form of radicular peripheral neuropathy. He says that he's particularly healthy, although he does get some headaches. So what we want to check now is the suboccipital tone. So I'm going to feel into the suboccipital tendons, particularly on the right-hand side. There's only soreness into there. Yeah, it's pretty sore. Feels very much like a guitar string for him here, right into there. Yeah, okay. This side isn't so bad, all right? But we can definitely feel tightness. And again, when a patient has chronic high-tone tendons and muscles that are painful, that merely indicates the nervous system is chronically holding them tight. And so a classic treatment might be, firstly, we want to do a manipulation. Okay, so I'm going to come into here. I'm going to manipulate the joint that is fixated. All right, so I'm going to rotate him around here. Nice deep breath in for me, Jack. All the way out, pop. I don't know if you heard that. That was a good adjustment. I'm going to do the same thing here. Skin drag right on the other side. Big breath in and all the way out. Hey, big adjustment there. Lots of nice movement. I'm going to turn you over onto your tummy for me. And we also found that he had some restrictions in his upper thorax, kind of. I think it might be worse on this side. No, actually worse on this side. There. All right, so we're going to take our modified cross bilateral adjustment. Going to come into here. Nice deep breath in for me, Jack. And all the way up. Good, well done, good man. Okay, turn over onto your back for me. And now a typical treatment, you do like a pin and stretch, a PFS, PNR, something of this nature. So I'll start off with a nice bit of distraction. And then what I'm going to get you to do is turn your head to the left for me. I'm going to pop this here. I'm going to get you to push your head back into my hand. Nice and relaxed. And then we're going to do big breath in, big stretch. Stretching out the suboccipital muscles here. And little distraction again. Relax for me. And all of this, the patient will regard as feeling great. Also, they'll have a great placebo response because that's what he's expecting to receive. So he's going to feel a lot better after this. Push back towards me. Nice deep breath in. Big stretch. Good. And sit up for me. Hopefully, we'll see a bit of a difference after that treatment. So sit up for me. Chin to chest, far down as you can. And there's a bit of improvement, which is great. Head up for me. You're going to rotate around for me as far as you can. Not perfect, but much better. Really quite happy with that. And to the left for me. Okay, the big difference, hopefully, go ear to shoulder on this side. Yeah, much better. So that's a real beautiful validation for PDTR, for chiropractic technique, for physical therapy, because there's no doubt it creates real change. Stand up for me. And what I want you to do is jump up and down a few times. Okay, move your arms. Okay, think about the way that your neck has hurt you, and sit back down for me. Now let's have another check to see how he's doing. So I'm going to rotate around here for me as far as you can, and it's come back again. Bring the ear to the shoulder, and he can't do it anymore. And go this way for me, and he struggles. All right, so what's happened there? Well, what's happened is that from a physical therapy lens, we try to manipulate the joints to try to perhaps break up periarticular adhesions, try to normalize the length of the ligaments, and in order to try to reduce muscle tone. And so when we do that, the nervous system then can relax and allow the range of motion to come back. But as we've seen, the issue was never the structural problem. Remember, the tightness in the muscles was the solution the nervous system came up with and was never the problem. And so if we're just addressing the solution by trying to relax down the muscles, we're only going to be at best a temporary problem until Jack here re-triggers the sensitivity. Then the nervous system will have to reinstigate the solution, which is tightening them up again. And so what I'm much more interested in PDTR, rather than doing all the manual work, which is great and will help him, we want to actually identify what the real cause of the problem is and fix it. And so using PDTR, what I'm more interested in doing is identifying what the solution of the nervous system is, which muscles are tight, which ones are weak, and actually find out the reason for that and normalizing tone. So let's have a look. So head back for me. So we're going to look at the suboccipital muscles. Suboccipital muscles are super important and one of the principal causes of headaches and tension type headaches. So I'm going to try and push Jack forwards. Nice and strong, no problem at all. And when we look at parallel lines, that should cause a relaxation or inhibition, which doesn't happen. Okay, now let's see what else we can find. I'm going to drop the head down. Strong for me. And his longest deep neck flexors, longest collie, completely weak. Nothing there at all. And so one would expect that because it's a habituation when we have that poor posture, our chin we collapse through the thorax and we poke our chin, causing a relative upregulation of the tension in my suboccipital muscles and a relative lengthening of longus colli, causing this adaptive response. What is the problem? Well, let's see. Why is his neck flexors weak? Strong for me. Completely weak. Try again. Okay, where's that weakness coming from? Well, let's see. I'm going to press into the articular pillars of the facets on the left-hand side and hit a reflex. Remember, strength is a reflex, and we need a reflex to reset a reflex. Does that help him? No. I'm going to press into the articular pillars on the right-hand side. Hit a reflex. Drop that down. Does that help him? Yes, immediately becomes strong. The other thing I want to know, head back for me, is does that cause relaxation of his suboccipital muscles? Strong. Look here for me. Try again. I'm not sure. Try again. No, there's a secondary issue going on here. So let's have a little feel down into his thorax. Head back, look at lines. Relax for me. Yeah, there. Okay, so actually Jack has two issues, not one. He has a little sensitivity higher up in his neck, and a little sensitivity in the junction between his thorax and his cervical spine. So hopefully, if we correct both of those very quickly, although you'll understand in depth how to do that using PDTR, what we find is, head back for me. Okay. The back of the neck relaxes. Sit up for me. The front is fine. Now we check the range of motion. Turn around this way for me as far as you can. Nice. And the other way. Good. And ear to shoulder. Nice. But the most important thing is we don't care about that because that's just a change that anyone can see on the bench. We want to see that the change is reproducible and he will stay like that after activity. So jump up for me. Lots of jumps and squats, really try and aggravate the problem. Big squats like you did last time, moving the neck. Okay, come and sit down for me. Now this is the real test. We don't care about distracting or calming down things and then sending the patient off. We care about real change. So, chin to the chest for me if you can. Nice. And rotate around this way if you can. Perfect. And go ear to the shoulder if you can. Beautiful. And ear to the shoulder on this side. Perfect. And rotate this side. But we also then, from a PDTR lens, want to not just see the range of motion as return, but the response to testing remains the same, meaning he can create strength in that flexed forward position. Perfect. And bring the head back, strong if you can. And we want to see also that he relaxes. And he can normally. So where we go from here with Jack is because he will have had an adaptive response so long, we then need to start to build in. So where we go with Jack now is I need to give him some rehabilitation exercises to start to open up his chest. So a lot of thoracic mobility exercises to try to come from here to here. And we want to give him lots of neck strengthening exercises. Send him away for a week to trial that. Then we bring him back in. And what we want to see is the range of motion is still normal. And the movements are still normal. And he responds to the parallel lines in a normal way. Because then we can say confidently that not only has there been real change that has spanned a week, but there's been real change and he's been able to do his rehabilitation exercises.
Would you like to learn more about PDTR? Would you like to be able to do what Stephen does? Sign up for one of our courses here in this link.